It's a great pleasure now to introduce our second keynote speaker, or really our third, with the Admiral, and that's Dr. Ronald Paulus. Dr. Paulus did us a disservice. He recruited Dr. William Maples to Asheville, to Mission Health, to be Senior Vice President. But we didn't know that he would be generous enough to let Dr. Maples continue on our faculty and come out and help us, because he, of course, is invaluable to this process. It would not be possible to have completed the courses without the initiation of the training of the Quality Steering Committee, and been the lead in the 3 courses that have trained nearly 60 faculty members who've had 40 hours of course. So, Ron, we're really indebted to you for letting us continue this relationship this way. Ron went to medical school in Pennsylvania, went to Wharton for his MBA, went to UCLA for a residency program in internal medicine. He got involved in communications and relationships with systems very early on, founded a company which did very well, was co-founder in another one which did very well, and became the Senior Vice President of Geisinger for Clinical Affairs. That was a $2.3 billion enterprise. Mission Health is a $1.2 billion enterprise. Had a considerable increase in its 800 plus staff while he was there, and Mission Health in Asheville is growing rapidly too.
Thanks, Yank, for that introduction. And before I kick it off, I just have to say, how about Team Mission today? Ladies and Bill. With a team like that, you know, I don't have anything to do. I can just screw around in Raleigh with the legislators and take my time there. You know, a couple of comments have come up about, obviously, the communication courses and Pearls. I'll just share my 2 most appreciative moments with Pearls. One is, and Bill can attest to this, I regularly say this in my executive team meetings, guys, I'm going to get all pearly on you. You know, and then the other one is at home when my spouse tells me, stop pearling me. And I'm sure you've experienced some of those same things. So I'm here to talk about creating change. How do we get there? What does it take? And I certainly hope I get the answer by the end of this interaction, because I've got a lot of work to do. Kelly and Susan gave you a brief overview about Mission. There's the state of North Carolina. We serve the 18 westernmost counties within the state, so it's generally more rural and so forth. This is Asheville cityscape at night. The Biltmore Mansion brings a lot of people there. A lot of outdoor activities, and fall is an absolutely spectacular time. And then this is Mission Health sitting up partway up the hill. 2 hospitals currently on different campuses across the street from one another. And then we have a series of smaller hospitals, 2 critical access hospitals, 2 would-be critical access hospitals in the several hundred-mile radius around us. And it's a mixed medical staff model, so about maybe 1/3 employed, 2/3 not employed, 850 odd physicians on, not odd, 850 various and sundry physicians. Well, some of them are odd, but they're really good for the most part. And you know, we speak at Mission in a very succinct, direct way. This is a somewhat variation of the triple aim from IHI, but we call it our bigger aim, to get each and every patient to their desired outcome, first without harm, also without waste, and with an exceptional experience for the patient and family. We have some challenges in Western North Carolina. These were challenges similar to what we had in central Pennsylvania, which is actually demographically and otherwise similar. It even has mountains, although they're really hills. We just call them mountains in Pennsylvania. We are older, poorer, and sicker than state and national averages by a significant margin. We're clearly less healthy behaviors if you look at the data, and particularly if you exclude Asheville proper, which is more of an eclectic, it's like San Francisco in the mountains, but if you exclude Asheville, a series of very unhealthy behaviors. We're a lot less likely to be insured. Asheville has about 25% uninsured status, that's or for the region. We're older, so the over 65 segment is the fastest growing demographic segment, over 85 fastest growing subsegment. And if you think about the utilization patterns, what that translates to for Mission Health is 7,000 incremental admissions per year from in-place aging alone over the next decade. So it's a big issue. And our payer mix is, and normally when I say this, the first thing, if people are familiar with healthcare, they say, can't be true. 78% Medicare, Medicaid, no pay. And then I say it is true, and they say, what the hell did you go there? And I don't have a good answer, but no, it's a wonderful place, and it's a community that requires a lot of service. Unfortunately, there's a large number of rich people. They're all Medicare. So it doesn't help when it comes to the reimbursement model that we have in America. So culture change. Wow, and this isn't rhetorical. You know, is there anything more difficult than that? This was a graphical representation of the old adage, you know, culture eats strategy for lunch. And then I have two, absolutely love these comics, particularly, Bill, this one's for you, Quality, Quality, Quality Zombies. It's working, all the employees are brainwashed, I'm done, I've transformed the culture, things sure have changed, yeah, my arms are tired. You know? The one I like even more, and I translate this one into the communications course, here's a list of 12 elements of great management. If you do all these things, I will feel what experts call engaged. If you fail to do this, I will be disengaged and do poor work. And you can read the rest of it, but it's an interesting phenomenon. I think, you know, Dilbert really captures the office culture, and healthcare is different, but it still has some of those same. If we move beyond comics into academia, Edgar Schein is the person who I give my most personal weight to in terms of writing, you know, in a really robust way around culture change. And he talked about the primary and secondary mechanisms of culture change. And the things that are on the secondary list are the things you often see people focusing on. You know, what's our mission statement? You know, what are our buildings like? All those kinds of things. But the primary mechanisms, the ones that really drive behavioral change and culture change, are things that smart people take notice to. What do you measure? What do you pay attention to? What do you control? Who do you reward? Why do you reward them? So for example, if I'm, you know, as the CEO, I'm out there and I'm saying, geez, quality is job number one, but everybody sees my eyes glaze over when people are going through quality and they see me really engaged when we're talking about finances, then people know it's not quality, it's finances that's number one. A derivation of this work really creates three levels with an increasing impact on engagement and on culture. And so the things that are most obvious to many, buildings, furnishings, reward structures, and all that, at the one end, the level two, mission statements, slogans, operational credos, buttons, bumper stickers, posters. But the level three it's the undisclosed, hidden, and unconscious unspoken rules, assumptions, and beliefs, perceptions, thoughts, and feelings, primarily manifest through everyday interactions back and forth between people that work, particularly leaders and the people that they interact with. And so that's really the cultural continuum as I think about it. And then as my colleague said earlier today, this is the most powerful change article that I think has ever been written, both how do you make change and why do things fail. And Cotter breaks down the 8 steps that you saw earlier this morning in that sort of iceberg step: establishing urgency, forming a guiding coalition, creating a vision, communicating the vision, empowering others to act, planning for and creating short-term wins so you keep momentum going, consolidating those improvements to produce ongoing change, and then institutionalizing those approaches. And you'll see bits and pieces of all of that in the work that I'll describe. And Bill, why did you ask me to present all your work, you know, whenever, but you'll see his handprints, you know, all over this. Now, I've been at Mission for about 2.5 years. I arrived in September of 2010. Bill started in December. And I had a retreat, and I can't remember, were you there yet? So it was probably in December that we had this retreat. And at the end of the retreat, we voted on what was the most single thing we could change that would have the most robust impact on where we wanted to go. And this was before all the pearls and all the relationship-centered leadership and all the other safety work that we'd done. And people voted number one was culture. But the question is how? And this is where I screw around a little bit with the Cotter stuff. So, I put vision first. Because until you have some place, some shining city on the hill that people can say, okay, even if I'm skeptical, I would agree that if we could get there, I'd want to go there. I still feel like that's the first thing that has to come. And, that's how we got to this bigger aim. Every patient to their desired outcome, no harm, no waste, exceptional experience. But beyond that, you've heard this in a number of the questions from the audience and in the discussion, it really revolves around putting the patient at the center. Because once you do that and have the patient front and center, and we've tried to do this in so many different ways, including embedding patients on our design teams, following patients in a value stream mapping process that I'll comment on in a bit, doing patient experience mapping at the same time we're doing value stream mapping, putting patients on our new facilities planning committees, and on and on and on. So this is work that's related to experience mapping from Bridget Duffy and Xperia Health, taking efficiency, linking it to empathy, that human connection that the admirals spoke so eloquently about. And that creates a healing experience, and in the sort of more business marketing lingo, it creates brand loyalty, customer loyalty, it creates repeat visits, it creates attention over time, it creates philanthropy, it creates all kinds of things within your institution and within your community. Okay. So, sense of urgency, that's early in the Cotter list. And for us, it's not that hard to talk about, the storm that's coming. So, recently, all of this Oklahoma City tragedy has created a lot of thinking, at least in my mind personally, thinking about that. And I learned, I didn't know this before the most recent events, on average you got 14 minutes from the time you get a tornado warning until you have to be in shelter. Not a lot of time, but on the other hand, the thing you have to do is not that complicated, right? So the real issue is, have you prepared a place that can be safe and reliable? And then 14 minutes, you got a pretty decent shot of getting there. And so what we've been talking about is, relative to scope and scale, what we have to do at Mission, and I doubt it's all that different from what you all have to do at your own institutions, is pretty comparable. Because the timeline is longer, we probably have a couple of years, but the amount of work to go from a volume-based system to a value-based system, to go from provider-centric to patient-centric, and the list goes on, that is incredible amount of transformational work. For Mission, I mentioned, those incremental admissions that are going to be coming from the community from in-place aging, but it manifests itself in an ironic economic model. Right now, the issue is, what capacity utilization can you operate at safely and effectively, particularly if you're a tertiary or quaternary referral center. So in that whole 18-county area that I described, there is only us in that role. So we really can't go on divert. There's no such thing. We have to take the next patient that's going to come in. So on average, you probably wouldn't want to go above 80% average occupancy, so you can take those surge periods. When we had the flu crisis, we were the closest to being on divert the institution's ever been, and so forth and so on. In addition to not being on divert, there's an economic stranglehold that occurs if you achieve maximum capacity, because your revenue is fixed and your costs are not fixed. So what happens to your margins? They go like this. And so, the urgency that we have is really about how do we keep this from happening, because this is the natural steady state. Left unattended, that's what will happen, and that's the world that we're in. And then, we have all these other things. For North Carolina, one of the big things was that in a very deliberate, thoughtful 48-hour period, our state chose not to expand Medicaid. They went a step further, which was actually interesting, that they actually created a law that said, and you're not allowed to talk with the federal government about it unless you're legally required to do so. We had a couple of other interesting acts, but that was a big deal. We know we have, and you've done all your own calculations, I'm sure, we have $310 million worth of reimbursement cuts coming over the next decade from the ACA, from the sequester, and the various other coding adjustments, and so forth and so on. So then you say, what else could happen? And just when you think it can't get any worse, it does. So in our state, there's been and there's even a second one, I just didn't have time to do the screen capture, where even this amount of overage that came in this breaking news alert, $248 million over budget in Medicaid, it's now 367 some million that it's supposedly over. They don't describe how they do the calculation, or the fact that Medicaid programs don't do actuarial planning and don't have reserves, so just a minor detail for an insurance plan. And so the devastation that is headed our way is not unlike, what happens in very bad outcomes. Okay. So that's the 2-minute version of the sense of urgency. But I think you can see that there's many reasons there. What about building a coalition? So this is something else that's come up, and I got to give great privilege and appreciation to Bill. Okay, I'm not going to be that pearly. I'm going to just say it like this. It's easier to say no to God, and I've done it, than it is to Bill Maples. I'm sure some of you in the room can appreciate this. But what we did is we say, look, we can't do the work. This is what I did as the CEO. We cannot do the work that we have to do for quality and safety and moving towards efficiency and just add it on top of everybody's daily work. We have to do something different. So I built up some trust. I made the pitch, and the board agreed to a $5 million incremental investment in staff, 80 FTEs for performance engineers, and to backfill physicians and other clinicians so that we could take our normal caregivers, have them on the design and engineering teams, but backfill them with staff so that it wasn't double, triple duty. And we're in the midst of that right now. And then, you see this sort of coalition building that's happening. People have to interact as human beings. They have to be in the room together. They have to be talking and engaged, arguing, fighting, whatever it might be, but they have to interact. And so probably most of you are familiar with the value stream mapping process. You take a caregiver out of their normal role. They have a zipper. They're not allowed to talk and intervene, but they watch what happens to patients from the patient's perspective. They track the value-added services versus the non-value-added services. We map all that together. We had Dr. Duffy's team doing some experience mapping in parallel. How does it feel while you're waiting? Are you being taken care of effectively? And so forth and so on. We then analyze all that data along with a lot of other data. We do visioning. What's the future state ideation? What do we want it to be? And one of the things I like to do to get people thinking is to say, don't get into any of the stuff about we don't have the money, the reimbursement model doesn't work, they don't have the incentive. Just imagine you're in fantasy land, you have a magic wand, and how would you make it if you could? And then you work backwards from there as to what your constraints are. But if you don't unleash the constraints up front, you'll never get to the ideation model that you want. And then ultimately, the other thing that we're doing because of that capacity constraint that I talked about is we're planning for a new building. And so we want to re-engineer our processes. Earlier, somebody asked about the electronic health record. And look, the electronic health record is more good than bad. It creates new problems, right? So you replace old problems for new problems. But the single worst thing that anybody can do is to implement the old workflow in the new electronic record. And since everybody's slamming the darn thing in to get the meaningful use money and not doing it to re-engineer care, that's how we get into a lot of these dilemmas. So, you know, lots of different places and times where people are. And this is, just to show you I'm a transparent guy, this was the single worst value stream mapping outcome we had. 7.9% value add from a patient's perspective. Now, come on, that's not even 10%. That is seriously bad. And everybody, you know, they mapped it all out as to what could happen. And, you know, they began to re-engineer. And then relative to the short-term wins, here's what happened. We had, and it's not socially acceptable for me to bring the real graph, so we trimmed it. If you went back before September, the left without being seen rate was actually above 9%. And we had 2 sentinel events where patients left without being seen, went home and died at home in the midst of it, one in an MI, another one with another serious condition. We brought it from 9% down to below 1. We hit the flu epidemic, and that was not an ED problem. That was a output from the ED problem, meaning there was no bed anywhere. And we went back up, but we never went back up to the peaks that we had from before. And now we've had a pretty good steady state around 2%. This is with 110,000 visits per year in a 58-bed ED, 12 of which are hallway beds, and 20 to 30% of those beds at any given time being with mental health patients that have been there from 1 day to 2 weeks waiting for disposition somewhere. So take 1/3 of that 58-bed capacity out, and that's the circumstance that we're managing. Another thing that I would note about importance of cultural change is that it goes back to the shine work. People look at what you do. So they want to know when you're the CEO or, you know, whomever coming in, what do you do first? What's the first thing you do? And what are the first 5 things or 10 things that you do? And so we decided to make, you know, our early investments in safety and quality, patient experience. This was Dr. Maple's brainchild. You saw from Dr. Leonard a different hospital in their public display. We have these quality boards on every one of our units. They're there for the patients, for the families, for the docs, for the nurses. Senior leadership rounds at those boards once a week. And we engage with the staff. We ask them to explain the data, look at the trends, tell us what barriers are getting in their way from doing better. But that visible presence of leadership out and about and the public display and the tracking of the metrics, absolutely critical to the transformation of the psychology of the institution. We've done many different things. Our communication in healthcare, relationship-centered leadership, our redesign work, and so forth and so on. And here's some of the data from that work that Bill has led and Susan has been involved with and so many others. We trained, this is over 4,100 allied staff trained, 515 physicians trained. Now I will note, relative to one of the other panelists, this is an incentive for communication in healthcare at Mission. At the end of it, and I just had a chat with one of the Mayo docs who was describing in one of her sessions, you know, welcome, why are you here? I'm only here for the iPad. But it ended well, I was told. I suggested an alternative response, but we believe that having iPads, since iPads are important for communication and we're doing a lot of Cerner work on our iPads now and all that, that was a contextually appropriate incentive scheme to get the docs there. And you can see with the red line when we started the training and then what happened to a patient's perception of overall teamwork in the hospital. Not arguing direct causality, but I believe that it was related. And then the percentage of those ranking mission excellent. Here's another one, same group. When we started the training, overall level of safety. Another one, physician communication, keeping the patient informed. When we started the training, where we've gone since then. And then here's a very specific thing, handoffs within our cardiac catheterization suite, where there were serious problems, and then went through and had that improvement. And then last but not least, starting at overall patient experience, overall quality of care in the 65th percentile, now at the 90th percentile nationally, all within a little over 2 year period of time. That's a pretty big change, and I think directly related to all of these activities. Now, when the Admiral got into the patient engagement and activation, I slipped these slides into my talk. This is the only that I'm talking about that we did at Geisinger, so this is not related to mission, but this is a quote from Bodenheimer about, people are the ones that make their own decisions. They wake up, they decide if they're going to take their medicine, if they're going to exercise, what they're going to eat. And that's why I've always said, and I mean this absolutely explicitly, there is no such thing as patient noncompliance. It does not exist. They just comply with a different plan than the one we give them. And there's a very important distinction in that, and it's not just a joke. So this is from Judy Hibbert's work, which the Admiral referenced, different levels of activation, a bell-shaped curve of the distribution, tails are smaller. This is evidence of what those patients do. This is for hypertension. Do they take their meds? Do they know what it should be? Do they monitor it? Do they keep a diary? Do they wear a continuously monitoring watch? That's the weird subset that I'm included in. And so we were trying to figure this out at Geisinger, and this gets back to one of the earlier questions. So I worked this in for two reasons. How do you use the computer effectively in engaging patients? I mentioned in the sidebar conversations, one of the things that we did at Geisinger was every new doctor goes through a training program that says, here's how you interact with the computer and the patient at the same time. And you can't start practicing until you pass an actor-patient test of that skill set. It also means the rooms have to be designed properly. You can't have the screen here and the patient here. There's no way to do it. But we went beyond that. We said, what else can we do with the computers, given that they're in all the rooms now? So we swapped out, this was part of my innovation work at Geisinger, we swapped out all of the screens in the doctor-patient room with touchscreens. The nurse would room the patient and turn the screen around and say, your doctor would like you to answer these questions before he or she comes into the room. I viewed this purely as productivity initially. Why ask $5 an hour questions for a $300 an hour person? But it was way beyond that. And so we wanted to give patients a voice to capture structured data without doctors or nurses, having to do it, without paying for scribes, enable real-time analytics, and so forth. And this was the early prototype that we did around patient engagement for heart disease. So we have a database. We have their LDL, their HDL, their family history, their blood pressure, what medications they're on. We used a modified Framingham model. We calculated their 5-year, 10-year risk of a heart attack or stroke, and then we presented that to them on the computer screen, okay? So you can see your risk is currently in the red bar, 12.2%. For the numeracy is a whole separate interesting topic, and this was just scratching the surface. But we know some people don't understand percentages. Other people, like 1 in X. And if you haven't studied numeracy at all, it may floor you to know that if you tell somebody there's a 10% chance of something versus a 1 in 10, they'll give you totally different answers on average. It's one of the things that I hold in wonderment, Bill. So you currently have a 1 in 8 chance of a heart attack, and we think if we did everything just right with you, if you were engaged with us, we could make it 1 in 21. And then on the right side of the screen is a touch, and it says, what would you be willing to do? And watch the green bar. So if I touch, I want to take medication, now I've gone from 12.2 down to 8.3. If I'm also willing to see a dietitian and exercise, I'm down to 5.8. You can keep going to your heart's content. Now, look at the bottom on the right. This was my major contribution, although I didn't get what I wanted. That says I don't want to do anything. I begged and begged and begged to say, please have it say, I don't want to do a damn thing. And that's not a joke. And they would not let me say that, but I don't want to do anything. You know what percentage of people click that button? 18%. 18%. Now, that doesn't mean you quit. It means that now the doc enters the room. They have all this data. They know what the patient's willing to do, not willing to do. They know if they clicked, I don't want to do anything. And you start the conversation from a position of knowledge and a position of empathy. Because then the conversation begins, Mrs. Jones, I see you don't want to do anything. Let's talk about that. There's always a reason. The most common are economic or a fear of a sex-related side effect. That's a fact, at least at Geisinger. I don't know about the rest of the world. And at the end, we would have a screen that said, here are your choices that you've made. If anything that they could have chosen would help them more than what they did, it's placed on the screen above. So you could see here they only want to do two things, but the medication is the single most effective thing they could do. And that's how the process gets started. So I slipped that activation thing in. Now, consolidating and institutionalizing. One of the things that around safety in particular that consolidating and institutionalizing is you have to understand what drives failure, right? So it's not just how do we lock these things in, it's how do we get rid of the things that otherwise undermine these good things that we want to do. And the most common things are the things, and this is from Jerry Hickson's work and others, the most common things are the subtle things. They see people not washing their hands. They see people just skimming through a timeout. They don't really do it. All that kind of stuff. People show up late for meetings, all that kind of thing. These are also from Dr. Hickson's work, looking at surgical adverse outcomes and what happens based upon the complexity of the patient. And this ties into physician behavior and comfortability in speaking and the ability for staff to speak up. And what you see is, from a NISQIP standpoint, if patients are not complex, both good doctors and bad actor doctors do well. But as the complexity of the patient increases, the spread between those good doctors, and I'm not talking about technical skills, I'm talking about Dr. Leonard's units where people feel safe or where they don't feel safe, you see a dramatic spread. And the same thing happens both at academic and community centers with, it's a small subset of the people that drive the majority of the adverse outcomes and the majority of the malpractice cases, patient complaints, grievances, you name it. And so what Dr. Hickson and others at Vanderbilt have created is this model of professionalism that we've adopted, this pyramid that basically says, look, and this ties into the just culture work that Dr. Leonard mentioned, most people don't have a lot of issues. When they do, the first thing you do is you have what he calls, and I really like this, you have a cup of coffee. You stop by their office, you have a cup of coffee, you take a sip, you say, I want to just know, Nurse Jones, on 5 West just reported you didn't wash your hands last time you were there. You don't get into a discussion, you don't debate it, you don't say anything else about it, it's just somebody was watching. And then you move up the pyramid based upon, what it is that you're doing. So it starts with a cup of coffee, sometimes you have to go to espresso. Now, Bill, we haven't talked about this and I don't have your approval. I wanted to insert a new thing, which is a shot of tequila. So we'll have to get Jerry's approval for that, but I think there's a role. Another thing that we're doing to hardwire safety is Bill and others created this, I think, relatively unique, not totally unique. That's an oxymoron. The patient safety structure. A patient safety officer, doc, nurse pair at the center, and then doc-nurse pairs across the key functional areas of the institution. And they have time, and they have responsibilities, and they have deliverables, and so forth. And at Mission, we started capturing patient safety events. These are events that may not have led to a problem, but could potentially have led to a problem. And look at the slope of that curve. That's people coming to life for the first time and describing things that have been going on forever but not talking about. Our most common categories are the things that you would expect. And each one of these gets a root cause analysis. Somebody earlier today talked about all the different ways a process could be broken. Those are the yellow triangles. And so we build a library of these things. And this is how we're monitoring status, which is which ones are in various stages of work. And then, thank God, there's a subset that are 100% complete. Review time's coming. This is where we are. It's going very well. And this is just a collage of work that we've done over the last 2 years. This is urinary tract infections before and after. Respiratory infections. Glucose control before. Green is good, red is bad. Glucose control after. Average vent days per vented patient. Average length of stay in the ICU. Propofol bottles used. CLABSI rate. Med rec, and then most important of all, and this is kind of what it's all about. This was our observed to expected mortality ratio from when we started 2.5 years ago, comparing to the top 16% of the US. This is not, if I did it on a US average, it would have gone from 0.96 to 0.6. With the top 16 comparison, it went from 1.6 to 0.8. At Mission alone, that's 550 patients who don't die now that would have died in 2010 per year. Every one of them is a person. It's not a number. It's not a statistic. That's a mother, daughter, son, father, brother, sister who went home who wouldn't have gone home before. So that's my walk through the cultural change. We're still in, it's a work in progress, as my colleagues can attest every single day. But we get out of bed every morning. We're emboldened and proud of the work that's been done. And we have the energy and desire to push forward to levels that we've never been to. It's the discovery of the new that is really what makes things interesting. So hopefully you saw in there a lot of repetitive themes from earlier today. That's hopefully a good thing, not a bad thing. It's our journey, and I appreciate you giving me the chance to come and share with you. And I've learned a lot here today, and I look forward to learning more over time. Thanks.